You know, a lot of this weekend was focused on trying to understand just a male white hairline, and I think it's a great way to start because it's probably the most common indication you're going to see in your practice. But we want to talk a little bit today about cultural sensitivity and just ideas of diseases that can occur in different ethnicities. We're going to focus specifically on African hair disorders from a clinical standpoint. I'm probably not the best person to talk about dermatologic conditions, but at the same time it's going to be important as a component to the surgical management, or at least thinking of it in preoperative and postoperative setting. Variations in hairline design that you heard Dr. Epstein allude to, and other technical considerations that I think are valid as you get more mature in your practice. So the key here is understanding that the African patient offers a challenge beyond the surgical one, which is trying to understand what clinical conditions could impair you from doing surgery or that you need to understand. Just by the very nature of the hair shaft, it's a drier hair shaft that has a higher predilection toward cuticle damage. And in addition to that, then you also have the cultural desire today to straighten the hair. And straightening is a lot of chemical damage can cause even more problems to a hair that's already predisposed toward problems. And then you also add shampooing and other things that a lot of African American women in particular don't wash their hair as often, maybe even on a weekly basis or every other week, to minimize that further damage. There are certain conditions that you may have heard about, like tinea capitis, which is a condition that's found predominantly in inner city African children, and the thinking behind that, this fungal infection that occurs, is predisposed due to multiple factors, one of which is the fact that the children have less of a fatty sheath on their hair shaft that can predispose toward this fungal infection, which is less likely in adults. In addition to that, they have a higher incidence of tinea capitis because of just the nature of the cuticle that attracts it. So that's just something to look for in children, in African American children, especially in closely confined quarters. But it can occur in almost any subsector of demographic. Scarring alopecias we heard about yesterday from Dr. Cooley, and the huge thing is to understand what are the conditions you can operate on and the ones you cannot. So I just want to reiterate this component, which is traction alopecias, which are due to straightening and pulling the hair, where the hair follicle is permanently deprived of blood supply, can lead to permanent hair loss. And those candidates they're very good candidates for hair restoration, obviously with the maturity of understanding of developing a practice after you've done good hairline work and good central density work and getting your feet wet with that. But other conditions that can be significantly problematic is that they don't necessarily take up hair well, and they can be an active process, which you heard yesterday, which is centrifugal cicatricial alopecia. You say that 3 times fast. And it's something it's also been known in the past as hot comb alopecia. The thought is that due to styling products it could be contributing to it, but I think today we realize it as a distinct entity, a distinct dermatologic entity that has maybe not as much relevance toward styling products than we thought in the past, which occurred principally toward the mid-scalps back into the vertex as indicated. So other conditions also that occur, and these are principally in the African male patient, because of the curly nature of the hair, when they are shaving, they can create problems. So there's 2 conditions. One is pseudofolliculitis barbae, and one is folliculitis barbae. Folliculitis barbae is just the condition of the curly hair, even stabbing the skin back and creating infections in this area, like staph infections in this area, that could lead subsequently to even keloids or just recurrent infections that can even lead to abscesses, and which we're going to talk about in just a second. There's another condition called pseudofolliculitis barbae, which is due to shaving. When the area is shaved and the skin is pulled back taut, the hair follicle can actually penetrate through a separate orifice or through the skin itself, and that action can cause a type of folliculitis known as pseudofolliculitis barbae. And then both of these conditions, if you have chronic and recurrent infections, can lead to conditions such as something called folliculitis keloidis, which is a keloid condition that's more predominant due to the close hair shaving styles. I just saw a patient last week with this especially in the occipital region, where this area is more prone toward keloids to begin with, and then when it's shaved very closely, you can have problems. And this treatment is something that I really would refer to dermatologic colleagues. I mean, it involves a lot of patience and steroids, managing the hairstyling options so they're not so close, and also managing them from like tetracycline or types of antibiotics that would cover the skin flora. Dissecting cellulitis is a very advanced condition where some African Americans can actually get repeated abscesses and boggy abscesses that occur on the scalp. It's almost in a very advanced type of infection. And that's something, these are things that obviously would preclude hair restoration, or at least be something you would need to be contemplating as you're investigating a patient with these conditions. So these are just some examples, photographs to sort of reinforce the information. Traction alopecia you can see on the left being pulled back. You can see now sort of visually the distribution of central centrifugal cicatricial alopecia, or CCCA, formerly known as hot comb alopecia. Folliculitis barbae, you can see there, the tinea capitis with the subsequent hair loss, and then the keloidis type of pattern that typically occurs in an occipital region of the head. This is an example of one of my work of traction alopecia, and you can see the female hairline is completely different from a male hairline. You can actually see the ghost image of where to do your hair restoration, but this is a restoration for traction alopecia. A different type of styling with a relaxed style, where you can see that this is principally a temporal issue, and so this is a temporal reconstruction with hair restoration. And, pardon me, and you heard a little bit from Dr. Epstein earlier about that there's different styling options that are occurring for the African male, but also you have to understand that it is a different type of hairline. We're going to talk about that. It's straighter, and we're going to talk about compromising that a little bit if need be, and we're going to allude to what that is. And then the Asian shape is different. The Middle Eastern is more like the white. It depends on actually the demographic and where the background is. We're going to talk about that. And then we're going to talk about the complexity of understanding the nature of the Hispanic hairline, or the mestizo hairline. So an example is that, generally speaking, it's a pretty straight hairline, and with a very closely cropped hair, you can see that shape. And a lot of people come to you for that. And the question is it the right thing to do? Well, not necessarily always, because you may run out of donor hair, and it may be better for the other alternative styling option, which is just to shave the head. Shave the head clean, and that may be better, especially if the crown is opening. It is a different type of hairline. It's a much straighter hairline. There are really no sentinel hairs. I don't go and make that micro coastline that you heard that I do for the Caucasian male. Not very much zigzag. And the female hairline has a little less zigzag as well. So these are the nuances I don't want you necessarily to be labored with, but just to acknowledge and understand and perhaps advance to as you mature in your hair restoration practice. This is a gentleman that had a hair restoration on the before, actually. It was very spotty, the density was poor. You know, you could argue, would you counsel him about shaving his head? Well, the bridge is already burned. He has a large donor incision there that compels him forward toward a transplant. He's in the younger 30s, and he's already have his crown opening, so you got to ask some questions for yourself as what should you do? At this point, it made sense for me to give him good density throughout the hairline, central density, all the way to the crown, but I didn't have enough to go into the crown. And this is not exactly a straight line, but it is closing that frontal temporal recession better than he had before, and so it's almost a straight line, but there's a slight degree of recession on the sides so that I can get enough grafts to fill the area. That's me. So a rounder head, a wider aspect, and the hairline is rounder. And so some examples of my work here you can see in a Chinese male that it's a wider, longer hairline, and it's not so much of it's more convex, if you will, that matches the hairline. This is actually Chinese as well, and you can see that the hairline is a broader hairline. This is an Indian patient who has almost a female pattern, which is a retention of the hairline, which almost dictates to me where I'm going to have to do his reconstruction. You can't, put a new hairline way up high and have this ghost image sit in front. So we used that as our guide and then rebuilt this with a single session. All these have been single session reconstructions. The Middle Eastern male, obviously, when you start talking about these broad categories, you got to be careful because, where do they come from? Some of the North Africans are darker skinned. They may have African blood in them, or more North European blood, and so there's different shapes. But in general speaking, the pattern design that I generally wind up doing is something closer or analogous toward the white male, or the North European or the Central European shape design. This is a more conservative design. Again, this is actually a reconstruction. He had a hair transplant done before. The angles are poor, density is poor. It didn't do much temporal rebuild on him. It was a more conservative design. designed to rebuild the hairline, and very similar though. But you can see that his hairs are actually quite coarse and straight, so you ought to be very careful in terms of the angulation, because again, it look grafty and artificial, almost like an Asian hair, but the shape is different. This is a Iranian patient where he just really wanted more central density. Obviously, we reinforced the hairline, but we filled up the whole central mid-scalp as well, going back toward the crown. The Hispanic male is a little bit more convoluted in terms of cultural identity, because if you think about the history of the Caribbean basin of the idea of Hispanic, you have the African slave trade coming through, you have some of the indigenous Indians that, if you think about where the history they came from, they came over the Bering Strait, so they have more of an Asian look. And then you've got the conquistadors and the white colonialists that came over and settled. And so there's this intermingling of races, and you can go to Dominican Republic and they look primarily African. You can go to different parts of the Caribbean basin and see a different variety. So when we talk about the word Hispanic, it's a very, very culturally mixed one. It doesn't mean very much. So you have to look within that patient you're seeing, and besides sort of the cultural bounds, you have to look at sort of the ethnic, geographic bounds that are made up in that person. And so it can be more white, it can be more African, it can actually be more Asian. It just depends on what mix they have. So I know that adds a level of complexity. This is, I just put up a Hispanic one. It doesn't really mean much. This could also be just a standard, white reconstruction. And this is the power of actually of the central forelock and the little widow's peak to create that visual frame that's really, really nice, even though he didn't dye his hair on the after result. So the point of this photograph is just to get you to understand there's a lot of mixed marriages today, and the concept is not to be so dogmatic in your concept of race, because today obviously it's so much more broadly understood and conceived. So the goal is for you to think beyond that. But these are just sort of general boundaries I want you to be thinking about that we really haven't introduced earlier in the course, because I think this is more of an advanced topic. In terms of technical considerations, these are things that I don't want you to really get bogged down on, but they're worth knowing, so that you don't just go and have an African patient or Asian patient and just start the harvest and start everything as the same, because it is different. The curly nature of the black hair makes it harder to harvest in many respects, because there's a higher level of potential transection. So I don't take thin strips out, I take wider strips out. And if we use a multi-blade, you want to be very careful of transection. We often tend to take just a single strip and have the assistants work a little harder on the back end to get that dissected. The donor closure, really, because it's so curly, you really don't need a trichophytic closure. In fact, I think you're adding a level of risk with that. I mean, it's not to say you shouldn't do it, but there are multiple levels. One is that the curly nature covers the scar quite well. The second thing, you want to minimize tension, specifically also on African, because the risk of keloid formation is higher, and so you're adding a higher incidence potentially of that. So I rarely do a trichophytic on an African patient, but not to say if your colleague does it, it's wrong, or if you do, it's wrong, but there's some thoughts that you may want to think about. Plus, the curly nature of it, we talked about pseudoficulatus barbae, and you're worried about that hair shaft then not growing out the right way. So I'm not here to try to further traumatize a curly hair, so I don't do many trichophytic closures, just as a subtle point in African patients. Recipient sides, the angles are not so critical because it comes out curly, and you don't need to dense pack this, because the way that it dances across the scalp, it actually creates a lot of visual density already. But I do look at the angles. I do look at if they have native hairs, where their hairs are angled, so that the way that the shaft comes out, I will mimic their natural growth patterns. And this is just a graft dissection. We don't want to get very much into this, but because of the low contrast to contrast between scalp to hair, and the fact that it's so curly, you could potentially use slightly larger grafts of difollicular units. But again, this is a very advanced idea. I just want to introduce the concepts more than you're trying to furiously write down all this information. But it's also sent to you in a slide format. If you don't have that, we can get Karen to get it to you. And then for Asians, I think the donor harvesting is pretty similar to Caucasians. There is potentially, theoretically, more keloid risk in an Asian. I don't think it's significantly that much higher if you're careful with your work, but there is an incidence of keloids. Recipient sites, you really want to, as we talked about, keeping every angle really, really low for the Caucasian patient, you want to be doubly certain to do that in the Asian patient, specifically because it's so straight, round, black against lighter skin that there's a risk of it looking grafty and artificial. So I particularly stay very, very low, but it's just an idea just to remind you to stay low no matter really what you do, except maybe the African patient, you don't have to be quite as rigorous with that concept. Graft dissection tends to be easier if they don't go white because of the dark hair color and the thicker caliber of the shaft, and the placement can be somewhat easier as well for Asian patients. So conclusions: the key is just to be cognizant of the hair disorders. Obviously, we can't summarize that in a short time, and like the whole framework of this course is not meant to give you all the information. It's to say, hey, I need to go back and read that. I need to learn more about it. I got to understand that this is not the same thing. And so that's really what I want to hopefully get you to begin to understand. Good. Any questions?